Good afternoon, everyone, and buenos dias to our doctor from Spain, and welcome to join our webinar. And my name is Lucas from EziSurg Medical.
Hello and welcome, everyone. Thank you for joining us in today's webinar. My name is Tarek, and Lucas and I, we are both part of the international sales department at EziSurg. And today it is a great honor and pleasure for us to have 7 well-known doctors and professors with a great reputation and rich experience in the surgical field who will share their knowledge in our academic exchange meeting on thoracic surgery between China and Spain.
And okay, and now let us warmly welcome our director, Wentao from Shanghai Chest Hospital, and our director, Ricardo Guijarro Jorge from University General Hospital in Valencia, Spain, and Professor Gabriela Rosado Rodriguez from Hospital University Juan 23 of Tarragona, Spain, and Professor Li Wentao, Professor Yao Feng, and also Professor Yang Yunhai, Professor Chen Xinghua from Shanghai Chest Hospital. Yeah.
So now, first of all, I will introduce the agenda for today. We divide this webinar into 3 parts. First of all, there will be the introduction part where Director Fang and Director Ricardo will give us the opening speeches. And then we will have the main speech part where we divide the speakers into 2 groups. We will have the Chinese group and the Spanish group. And after each group, there will be 5 minutes for some open questions and for small discussion. Then the third part will include our live surgeries. And before we start the surgeries, Professor Xinghua will give us a case introduction. And during the surgeries, he will also give us more detailed information about each procedure. So now let's start with the first part. And therefore, I would like to welcome Director Fang and Director Ricardo to give us the opening speech. First of all, Director Fang will start with his opening speech.
Thank you. Good afternoon, good morning, our respected Spanish colleagues. Good afternoon, Chinese. It's a great pleasure for us to have this webinar together with our Spanish colleagues. And beside me, you will see Dr. Yao, who is our Deputy Chief at the Department of Thoracic Surgery, Shanghai Chest Hospital, and also Dr. Wentao Li, who has the same name with me, who is also a senior attending surgeon at our department. It's a great pleasure to have Professor Jorge and Rosado from Valencia and Tarragona in Spain to have this webinar together. Today, we're going to exchange our experience on minimally invasive surgery and enhance the recovery after surgery in lung cancers. I think more than 20 years ago, when I just started my career as a thoracic surgeon, most of our patients would have to receive surgery by open procedures. But now things have changed greatly, thanks to the development of science and technology in modern surgery. Today, almost 95% of the lung cancer patients at the Shanghai Chest Hospital will have minimally invasive procedures, including robotic surgery. This also is because of the increased use of CT scan, and a lot of patients with lung cancers are diagnosed at the early stage so that they can receive more simple procedures to have the disease removed. Also, owing to this increased use of minimally invasive surgical techniques, our patients are nowadays recovering much faster than they used to do. This reduced the pain, and the surgical trauma has helped greatly in minimalizing their length of hospital stay, reducing the medical costs, as well as improving the patient's quality of life. So I think today we're going to have a very interesting seminar, including talks on minimally the Miniportal VATS, the 3D Uniportal VATS, robotic surgery, and as well as how to manage our patients after surgery, including managing strategies for air leak after surgery and enhanced recovery after the surgery. So I believe that our colleagues online will benefit greatly from experience from both sides. And I also appreciate the contribution of our Spanish colleagues to this webinar. I sincerely hope that, like I said before, I hope that this COVID thing will soon be put to an end in the near future so that we can meet in person. And I would take this opportunity to extend our warmest welcome to all our colleagues from Spain to visit us in Shanghai so that we can have more communication and exchange in surgical management of lung cancers in the near future. Thank you very much.
Thank you for this great opening speech, Director Fang. And now we would like to welcome Director Ricardo to give us his opening speech.
Thank you, Professor Wentao Fang. Good morning here from Spain. It is a great honor for me to participate in this meeting with our colleagues from the Shanghai Pulmonary Hospital, a very important hospital in the world, pioneering in VATS surgery, and with important contributions in our specialty. We sent our residents in the past edition of Uniportal VATS surgery there to Shanghai, and it is our intention to maintain such collaboration in future opportunities due to the volume and quality of the surgeries you practice. They returned home enlightened of their stay there and learned many important surgical aspects thanks to your generosity in teaching them. I also want thanking to EziSurg company and its distributor in Spain, MBA company, the possibility of being connected and support this meeting. We would like to open today a way of future contribution for the best of both countries, always looking forward to the progress in our specialty, thoracic surgery. I will present first our VATS surgery, which concerns a lung volume reduction with a suspected malignant nodule in the bulle, to continue afterwards speaking the topic about the most frequent complication after stapling the lung, the persistent air leak, and its consequences. Though in this case we present a VATS surgery, I want to remark that we also practice a robotic surgery. Finally, I want to introduce my colleague, Dr. Gabriela Rosado Rodriguez from the Joan XXIII Hospital in Tarragona. She is an experienced surgeon in robotic surgery, and she will speak about the use of stapling in robotic surgery and its economical impact.
Yeah. Thanks.
Okay. Before the meeting starts, I would like to add a few words. Maybe you didn't notice that there are two major thoracic surgical centers in Shanghai. One is the Shanghai Chest Hospital, that's my hospital, and also the Shanghai Pulmonary Hospital, which used to be a TB institution, but now focuses mainly on lung cancer surgery. So beside me, Professor Li Wentao actually used to work at the Shanghai Pulmonary, but he joined us later because he's more interested in lung cancer surgery. So the difference between these two centers is that the major difference is that we do both lung and heart cardiac diseases. We also do esophageal surgery as well as mediastinal procedures. The Shanghai Pulmonary focuses mainly only on pulmonary diseases. but they also do an excellent job in doing lung cancer surgery. So I hope next time when you're in Shanghai, you could visit both of us, and you will see a different culture and experience techniques at these two places. Thank you.
Thank you.
Okay, thanks so much for the great opening speech from our Director Fang and Director Ricardo. Now let's turn to our second part of the webinar. First, we would like to invite our Professor Wentao Li of the Chinese group to give us the speech. The topic is Miniportal vets and extremely enhanced recovery after surgery. Let's welcome our Professor Wentao Li.
Okay, hello, everybody, every professor, and good morning in Spain, and good afternoon in Shanghai. Okay, the first speech is it's my topic. The name is Miniportal virus and extremity URAS. VATS is a minimal invasive technique that allows faster recovery after thoracic surgery. Laser surgical trauma on the chest will result in faster function recovery. From 2005, I started my vast experience from 3-port to 2-ports and Uniports. And I returned to the 2-port and become the very mini port. That's Diego name. Diego, your friend Diego Gonzalez. Gonzalez named you said the blood is very small, so you should say the mini port, not like us the Uniport. It's very small incisions. This is the video about the Miniportal left heart flopectomy. I will show the video. 可以转到前台吗？不能。可以转上来吗？图像转不上来。
这是视频对吧？就是你刚刚嵌入的视频是吧？
嗯。
你的文件夹里面放，就是
从这里放。
对，从就是放直接放你的硬件，对，放这个。
算了，不放了，没事。不放了，待会儿要分它有很多很精彩的东西，放。Okay, it's just the normal left flopectomy. Because the video can show the screen. Okay. Okay, usually I prefer to use a 2-port. Before 2005, I was studying was in Los Angeles with Dr. McKenna for 1 year. Before I performed was by 3-ports. Okay, the pulmonary arterial, the first branch, then the. Want to use a 2-port. Before 2005, I was studying was in the lingular branch artery. And from the fistula, all the fistula, we cut the up lobe. 谁来帮我弄？你过来帮我弄。回 我把它回来。这是刚才那个。Okay. The ERAS including the below protocol. First, it's a faster check protocol, and a multimodal and a multidisciplinary protocol. Decreased morbidity, shorter hospital stay, rapid rehabilitation. And more, all of the above the focus on to the one purpose is more satisfied the patient. This is our purpose. The guideline for enhanced recovery after lung surgery, recommendation of the ERAS Society and the ESTS. The key question, what is the optimal preoperative management for patient and going lung surgery? The key finding, recommendations were developed for 45 ERAS items from initial presentations through to the post-operative discharge. Taking home message, the use of the systematic multimodal pro-operative care pathway has the potential to improve the outcome after lung surgery. The ERAS including three phases: pre-operative, intraoperative, and post-operative. Our experience, pre-operative phase. Pre-operative informing is very important, and consulting also very important. And pre-operative fasting, avoid the conventional way of the pre-operative fasting. For example, 5 hour eating, the 2 hour drinking, because fasting leads to fasting. Intraoperative phase, the type of the anesthesia, usually we use the opioid, and the less invasive approach. I prefer the Miniportal. The minimal invasive approach within 2 Miniportal. Operating incision are not bigger than 2 centimeters. At the end, before placing chest tuber, we use the intercostal and the pleural block, like this. Okay, this is the subsegmentectomy in right upload. We find the anterior branch pulmonary vein. We cut it, and the dissection deeply to find the anterior pulmonary bronchus and branch, one of the branch, the posterior branch of the anterior bronchus, then cut it. And I use the green staple to cut the lung lung tissue. From the CT scan, the last. Okay. So we can do the pneumonectomy, the intrapercardial pneumonectomy, and a lot of lobectomy or complicated, for example, the sleeve or double sleeve lobectomy, and also many sigmoidectomy. So. Okay, there's the Miniport. It's a 2-port, but very small. Okay, this the after the post-operative, after surgery, you can find just one finger side. Yeah, this is the incisions. Okay, it's the intercostal and the pure block. Side. Before place the chest tuber, usually we use the intercostal block, nervous block, and the pure block, like this. Usually we use the lopecaine. Lopecaine is very useful for. After this injection, the patient they have no pain after surgery, no pain, almost 7 hours to 10 hours. So for us, just the operating day is enough. Okay, 回到原来的。The post-operative phase, a patient after surgery taken to PACU, extubated, not only the first day, even the first 50 minutes to 1 hour after extubation. Patients are verticalized, do some easy exercises, even autonomously are working to word. It's amazing. It's like this. Look. 怎么不能动了？刚才不能播吗？啊？这个我在上面都可以播的，那么到底下去。对，我回到文件，回到那个文件夹。是。我来播吧。OK， 顾桥上去了没？对，您先打开才能够。OK。对。Okay, that's why it's very special. Just surgery, the operating room.
好，然后把俯卧撑再做一下，俯卧撑。好，俯卧撑再做一下，俯卧撑再做一下，再做。好，可以了，做。
And again and again. 下一张，对，下一张。回到那个。Okay. Patient can talk after surgery. benefit of the Miniportal and in the US, the shorter hospital stay, as we know, and less complication rate. The patients are more satisfied and more comfortable after surgery, and less expense. More, I think is the most important is the more satisfied patients. And 来给我回到录像去。这个没法弄。
是。
转不了，来我来弄，别动。
这您说是哪一个？我来给他。
不是话筒上头。
我来给您共享上去。
Okay, look, this old man is 74 years old. It's my first case in our hospital, in Chest Hospital. 要顶着 Ronnie，
有病人没了。
要不然是现在麻烦啊。
咱把它。对，手术后就刚手术完1个小时之内，然后再回到那个文件夹里，我还放一张。好的。
这个
我来弄这个。上去了没有？
我来给你再上去。
你这什么玩意儿？I just want to show this video to show the patient smile.
两个都是网红。这边还有病人啊，别跑！你这样会红的。来拍个 pose， 来。
That's her face. Smile.
下一个啊。
好了，够了，我拍不下去。
下一个，好。这个弄不成。Okay, thanks.
Thank you so much, Professor Li, for this great speech about such an interesting and also important topic. Now, next, I'd like to welcome Professor Yao Feng, who will share his knowledge about the strategy and skills for 3D uniportal lung surgery in difficult situations.
Hello, my dear colleagues in Spain and in China, and I'm Dr. Yao from Shanghai Chest Hospital. I'm very honored to have this opportunity to share with you our experience in the 3D uniportal cases, and especially for today, I'd like to share the experience of strategy and skills for vessel lung surgery in difficult situations. First, I'd like to share our 3D uniportal lung surgery. You know, maybe from 4 or 5 years ago, we used the STOR's 3D equipment in our hospital, and we use this equipment to do 3D uniportal lung surgery. We think we like this equipment very much because for the uniportal, you know, in the single hole, just like my second picture, the 4 equipments always struggle with each other, fight with each other. You know, this is very difficult for us to do our operation very smoothly, very so we use 3D camera it has many advantages. For example, it has a very clear vision, a very precise anatomy, and a very good sense of depth. You know, this is very important, just like Da Vinci, very important for us to do anastomosis procedure, you know. And I think that another very important thing is you can see it from the, always see from the second picture, our assistant just held the hammer with his just one hand. And this camera is straight and very, I think it's very easy for him to hold this hammer for the single day, you know. The whole day, we do 6 cases. It's not my assistant. I think it's very relief of assistant fatigue, you know. So we like this procedure very much, and we use this. We have done more than 3,000 cases for 3D uniportal lung surgery. Today, the most important thing we show you the challenge of thoracic surgery. I think the first is locally advanced diseases. For example, we use we choose leaf lobectomy or pneumonectomy, VETs. And another situation is the tumor invading pulmonary artery. But this is not my topic today. My topic today is the second and third. Second is calcified lymph nodes. How to manage vessels and bronchus safely in this situation. And the third is unexpected bleeding. How to prevent and control the bleeding in this situation. I think the third topic is every single thoracic surgeon for us, we always face bleeding. We always have this problem. The first calcified lymph nodes, you know, in China, especially in northern part of China, we have a lot of patients with calcified lymph nodes. Always maybe because of tuberculosis, recurrent nodal inflammation subsequent to pulmonary fungus infection, or COPD. I can show you in this video. This is a right arboreal patient. You can see from here, just between the bronchus and the pulmonary artery trunk, there's a very sticky calcified lymph nodes. And this is another patient. Sorry, there's some problem with this mouse. This is another patient. As you can see, there's a calcified lymph node just between the right middle lobe and the lower bronchus. I think the most common site with this calcified lymph nodes was between the first 3 branches of pulmonary artery and the left upper bronchus, as you can see from this case. Between the bronchus and artery, there was a very difficult calcified lymph nodes. And this is another case. As you can see, between the lingular artery and the lingular bronchus, there's a calcified lymph nodes. I think one of the major causes of the vascular injury and unplanned conversion of vasculopectomy, which account for more than 36 to 41% of unplanned conversion. There are another 2 cases, as you can see. Also calcified lymph nodes between the branch of left upper artery. And this right upper lobectomy, As you can see from between the trunk of pulmonary artery and the vein, there's a calcified lymph nodes. So how to manage this difficult situation? Actually, we can conversion to open surgery, open procedure. But I can share you 2 tips maybe. The first is we can cut bronchus first. We need to cut the bronchus as distal as possible first. Sometimes we always cut the bronchus, the segmental bronchus, and then we keep a continuous suction through an endotracheal tube. In case of massive bleeding, Then we remove the calcified lymph nodes from the bronchial wall with a sharp dissection, always with the scissors. Then we can close the open bronchial stump with stapler. I can show you in 3 examples. This patient, as you can see, there's a calcified lymph nodes. We can cut the bronchus at the segmental bronchus. We cut first and deal with the pulmonary artery later. And we use the scissors to do a sharp dissection. And this is the second example. There's a lymph nodes between the right middle lobe and the right lower lobe. Then we cut the bronchus first. After that, we use scissors to do a sharp dissection. Remove the calcified lymph nodes from the bronchial wall. Then we use stapler to deal with the artery and then bronchus very safely. The third one, I think, is a very interesting case. This case, we plan to do right upper sleeve lobectomy, but we face calcified lymph nodes. For us, it's very difficult for us to deal with, especially the artery branch of A2, very difficult. But we can cut bronchus first. The first one, we cut the right main bronchus. Then we cut off intermediate bronchus. After that, we can deal with the A2 artery very safely and very easily with stapler. After that, we can do anastomosis. I think it's very easy for us to do this. And another tips I like to share with you is in this kind of situation, I think we should emphasize the importance of pre-block the main artery in this kind of situation. But this patient, we use we use to break the main artery, and then we can deal with the first branch of artery, and then bronchus, and then A2 artery. I think it's very safe to do this. As you can see from here, if we did not block the main artery, it's maybe very dangerous to do this. Okay, another we I think for every thoracic surgeon, we always face bleeding. How to prevent and manage this situation? I think maybe we can show you another examples. First, I should like to share with you the experience. We always do vessel dissection as long as possible, especially for Uniportal, because we think we can use longitude for angle, and we have more space for our stapler to enter, and this is maybe more safe for us to do operations. I can show you this case. For the right upper lobectomy, we use harmonic or use always to do vessel dissection as long as possible. And another example, oh, sorry. Another example, we how to deal with vein. As you can see, for the left upper lobectomy, we always dissect the vein as long as distal as segmental plane, and we have enough space and angle for us to enter our stapler. And I think it's very safe for us to do this. And then we always I think it's very important for us to do perivascular lymph node dissection to reduce vascular tension. I think this is very important for us to have more space for stapler. Oh, sorry. This is a right upper lobectomy. We always use, we do dissection, always perivascular lymph nodes and always tissues around the vessel, reduce the tension. This is another example. As you can see, we open the last layer of the tissue, around the tissue, to reduce the tension. I think another important tips for us is to pre-block the main pulmonary artery, as I mentioned earlier, for this prevent bleeding. This is another case. I think there's no enough space for us to enter the stapler, so we do block the pulmonary artery, main pulmonary artery. Then we can deal with vessels, bronchus, and the vein very safely. Okay, this is another example for the left side. For the left side, we can block pulmonary artery maybe more easy than right side. We like to use the tunicate for Uniportal case, but sometimes we like to use bulldog, or together. After blocking, we cut the bronchus first. this is actually a very difficult case, and we did pulmonary artery parasity. And this is example. This is a case is very, I think is very interesting. You know, because you can see lymph node, calcified lymph node just located between the lingual artery and lingual bronchus. We cannot block the left lower artery, so we block the inferior pulmonary vein. You know. Then we cut the artery and cut the bronchus, and we suture them. I think this is very safe. This is very easy. And in case of bleeding, how can we do? I think for this kind of small bleeding, I think it's very safe. We just need to compress with gas maybe for 3 to 5 minutes. I think it's very important, very easy to do this. But in this situation, as you can see, when we enter the stable, there's bleeding. I think this is catastrophe, you know, especially for left upper lobectomy. At this time, I think the most important thing is we can compress the artery with lung itself, you know. We cannot use we should leave the lung in itself. And in another case, in case of massive bleeding, we can also attempt to block. In this case, as you can see, the middle lobe lobectomy, massive bleeding. We can block the main artery. Then we can do it very safe. And the last one I can show you with you. This case, as you know, left upper lobectomy is maybe the most dangerous for us. In this situation, massive bleeding, we should always attempt to maybe conversion as soon as possible to open surgery. But before open, maybe we can attempt to block the main artery with bulldog. Yes. And the last case I share with you is another in massive bleeding. We can cut bronchus for better exposure. This is a very interesting case. I showed you earlier, yeah. But how to deal with this situation? After compression with lung itself, bleeding stopped. Then from the fissure, we cut the artery, and we cut the bronchus. We leave the first branch of the artery at last to deal with. So I think after deal with the bronchus, it's very safe for us to deal with the artery. So this is all I share with you our experience in Shanghai Chest. So maybe we can communicate with each other in the later life surgery. Okay, thank you very much.
Okay, thanks for the wonderful speech from our Professor Yao and Professor Li. Now we have 5 minutes for discussion. After discussion, we are going to welcome our Spanish team to give us the February speech. Okay, now the discussion part. And Dr. Ricardo and Dr. Gabriela, do you have any questions here?
No.
Hi, thanks for the excellent presentation. I have a question for Dr. Wentao Li. I see in your video a very tiny lesion in the lung. Which technique did you use to localize the tumor?
Not very clear. Can you say it again?
Okay. My question is for Dr. Wentao Li. In one of his videos, there was a very tiny lesion in the lung.
Yes.
Did you use some kind of radio localization of the tumor? Some radiopharmaco? How you localize the lesion?
Okay, I understand. This patient, yeah, I know this because why I showed this CT scan picture, because there's a very small incision and a lot of very small Bible, and a sick word Bible. The pathologist is early adenocarcinoma, lung cancer.
Yeah.
Yeah, but this this relation of the position is very special because it's among the 3 segmentectomy among anterior, posterior, and the apical.
Okay.
Among in the middle. Okay. In the middle of the 3 so it's very special. It's not the apical segmentectomy. It's not the anterior segmentectomy, not posterior. It's a sub segmentectomy. So it's a very special position.
Okay.
Thank you.
Congratulations for your wonderful presentations. I want only remark with the videos exposed by Wentao Li after surgery, only one question. When is produced the delivery from the hospital in an standard pulmonary resection? When the patient goes home after a standard pulmonary resection, how many hospitalary days?
Okay, that's a good question. I started this procedure from 2018, August 2018. And there's another hospital. I did the surgery in another hospital. We try, but that patient is very old. It's 84 years old. And I know we finished almost 1,000 cases for extremity errors. And I know today I have the 11 cases. 11 cases. I have finished 9 cases. The two cases left for the video shoot later. For today, 11 cases. Almost 7 or 8 cases. Tomorrow afternoon discharge. Tomorrow afternoon.
Oh, surprisingly.
Yeah. So it's good.
Congratulations. Congratulations.
Yeah. But I have the big problem. It's discharge, the patient discharge, but with chest tube.
Oh.
with chest tube because it's a natural recovery. We can't accelerate the recovery. It's a natural.
I understand. Thank you very much.
Yeah, thank you.
Thank you.
Any questions? More questions here? Yeah. Okay. Now, due to the lack of time, and thank you all of your questions. And now, next, we warmly invite our Spanish group to give us the speech. Firstly, we highly welcome our Dr. Ricardo to give us the speech with the topic, persistent air links and sealants in biportal thoracic surgery after mechanical stapling. Yeah, let's welcome. Okay, now, okay, let's play the video first.
Oh,
video, yes. Can we start the video now, Dr. Ricardo?
yes.
Okay. Yeah.
We present a case of a man, 49-year-old, referred from pneumology due to a CT finding of an anterior mediastinal lesion in el paraseptal emphysema. Inside the bulle, there was a nodular lesion with a diameter of 37 by 15 millimeters. These are the CT findings. And in the walls of the keys, there was a nodule that in PET scan was hot with a SUV of 6. So there was an hypermetabolic nodule with unknown origin in the walls of the keys, as you can see here in the slide. In the biportal identification of the nodule, the first step was to liberate the adhesion to the parietal wall. And you can see the important bulle in the apex of the lung. The liberation with a hook. This all was done by biportal approach. The lung was liberated with electrocautery. As you can see here. This is the nodule in the walls of the keys, which I remarked was hot in the PET scan. Which was liberated with Maryland instrument. Here we use the AC staplers, which are very feasible, very adequate in the sense that they have an angulation much more pronounced than the rest of the staples, so we can avoid to resect healthy lung thanks to the angulation of the instruments. This angulation can only be provided by this brand of staples, which is very convenient. This is the end of the resection of the bullet with a nodule in the wall, which was confirmed afterwards as an epidermic carcinoma. And the structure. We use a sealant in the suture line, in this case, a Biportal. Afterwards, if you want, I can explain more about this sealant. And a fibrillar surgical in the adhesion in the surgical field. In the end, we test the stability of the suture with no leak. This will be the topic of my presentation afterwards, the prevention of air leaks after stapling in lung surgery. And we end the operation playing the drainage, only one, in the apical position. No bubbles in the pleura. And this gives chance to my topic, which will be the prevention of air leak after stapling lung surgery. This will be the guide of my exposure. Patients with air leakage have an increase in other complications and a delayed hospital stay. Consequently, prevention and effective management are critical. Furthermore, postoperative air leaks has been reported in between 30 to 60% after lung resection, and prolonged air leak has been reported with an occurrence between 8 to 26%. The prevalence of air leaks in the European database of the ESTS is increased as bigger is the amount of lung resection. In lobectomies, as published in different papers, the incidence can reach up to 12%. Parenchymal leaks, that is alveolar pleural fistula following lung resections, must be distinguished from bronchopleural fistulas. Parenchymal or alveolar air leaks occur intraoperatively and usually represent lower flow air passages. In contrast, bronchopleural fistula generally develop days to weeks following anatomic resection, represent descents of the bronchial stem, are frequently accompanied by empyema, and can transmit a significant amount of the exhaled tidal volume depending on the extent of the descents. Instruments like the represented in the slide can measure the exact leakage in milliliter per breath or leakage in milliliter per minute. The device possesses software for data storage and therefore is reproducible in any data documentation. Parenchymal air leaks generally arise from three sources: the fissures, the parenchymal staple line, and an area immediately adjacent to the staple line and pleural adhesion at remote sites. There are two different classifications about measuring air leaks in thoracic surgery. The Macrorini scale measures the amount of leakage during surgery in 4 types: 0, no leakage; 1, single bubbles; 2, a stream of bubbles; and 3, coalescent bubbles. The second one, proposed by Serfolio, measures the air leaks after the operation and distinguishes continuous air leak, inspiratory air leak, expiratory air leak, and forced expiratory air leak. Predicting parenchymal air leakage following lung resection is difficult, but several risk factors have been proposed, such as the severity of obstructive pulmonary disease. Emphysematous lung may be a risk for air leakage, particularly after wedge resection, onto the staple line or the region subjacent to the divided margin. The type of surgery is another factor that must be undertaken into account. Persistent air leakage is more frequent after upper resection and wedge resection staple. Meticulous management of the future is also important to prevent air leak. The presence of pleural adhesion is also a source of air leaks. General parameters like lower level of serum albumin, advanced age, use of steroids, and induction chemotherapy are also proposed for prolonged air leakage. These prolonged air leaks are deleterious effects in the postoperative course, such as longer need for chest tube drainage, often associated with increased pain, prolonged hospital stay and increased costs, risks of pneumonia and emphysema, increased readmission to intensive care, decreased mobility, risks of thromboembolism, and furthermore, a continued air leak can necessitate pleurodesis or prolonged drainage with Heimlich valve or even reoperation. How can we get air seal after stapling in lung surgery? Two types of measures can be taken to prevent this, intraoperatively and postoperatively. Intraoperatively, the goal at the conclusion of any lung operation is to leave the operation room without an air leak. Blood loss during operation and any kind of air leak is undesirable and should be avoided if possible. All parenchymal and bronchial margins should be leak tested intraoperatively and the lung carefully but completely reinflated at the end of the operation. Any identified leak can often be repaired by horizontal matrix suturing using monofilament sutures. Sutures pledged with autologous pleura or bovine pericardium may be helpful to control parenchymal air leaks in emphysematous lung tissues. If a lung resection must be made not following anatomical pathways, it's advised to buttress the auto sutures better with lyophilized pericardium with PTFE buttresses, because pericardium is a living tissue that with the serum inflates and so minimize the leak around the staples in the suture line. This fact not happen with synthetic materials. Use of sealant is another important measure that can be taken during surgery. We will speak thoroughly about them afterwards. Another maneuvers are useful, such as to optimize lung inflation and minimize unfilled space. Initially, the lung should be released completely from all parietal pleural attachments. The inferior pulmonary ligaments should be divided up to the inferior pulmonary vein, and anterior and posterior reflection of the ileum dissected. Any adhesion between visceral and parietal pleura should be released carefully and the lung fully mobilized from the diaphragmatic surface to cupula. The mediastinal surfaces of the lung should also be free. There are other techniques that can be used to minimize air leaks, less frequently used, but not for that reason less practical, such as pleural tent, pleurectomy, or pleurodesis. Another circumstance that can prolong air leakage in the postoperative time is the extensive use of vacuum in the drainages. It is advisable not to use, but to adopt a water seal policy for chest tube management. Patients who had their tubes placed on water seal instead of wall suction were more likely to stop their leaks sooner. Only when there is an important pneumothorax, massive air leak, or progressive subcutaneous emphysema, drains should be placed in suction until resolution of these problems. In case of persistent air leak, with remaining lung adequate filling the space, patients can be discharged home with Heimlich valves and follow up in the outpatient setting until air leak resolution and chest tube removal. The choice of operation is dependent on whether a space is present or on the quality of the lung tissue. Talcum pleurodesis is another option, but it's necessary to take into account that its use can develop emphysema in patients. Reoperation for intractable air leakage is uncommon and should be considered only after other options have been exhausted or discounted. Now let's speak about the use of...
Dr. Ricardo, we learned a lot from your presentation. Thank you. I have a question for you. When you, maybe for you do the lung volume reduction surgery, especially for air leak, for the prevention of air leak after surgery, you just use the stapler or use other maybe other.
I don't quite understand.
Yeah.
The question is if I use staplers in lung volume.
You use other things to, in case of to prevent air leakage in this kind of patient.
If I use what?
Maybe some, in Spain you have some.
I don't know the word. If I use what?
Navi, you have Navi, a mesh from Japan named Navi to prevent air leakage.
I don't understand that word. Can explain, Lucas, in Spanish what is that? Explain in Chinese to him.
Do you have any mesh, like Navi mesh or the patch? Any kind of artificial patch?
Patches. Yes.
Patch to together with the stapler to prevent the air leak.
The question is if I use patches to prevent.
Do you use do you put a mesh or a patch inside inside the stapler together with the stapler to prevent air leak when you do the lung reduction?
I use patches made of pericardium or PTFE.
Oh yeah.
To reinforce the suture line. Yes.
Okay. Thank you.
Yes.
We understand. Thank you.
Can you see my presentation?
Yes, we can see your presentation. And please continue your presentation. Thanks. And Dr. Ricardo, could you please try again? Because we cannot see the PPT now.
Share the screen.
Yeah, just share the screen.
I was speaking about the use of sealants in modern thoracic surgery. Can you see it? Can you see the screen?
Yes.
Yes, yes, we can see the screen now.
Well,
and later, maybe our surgeon here, we go to prepare for the surgery. Yeah, because the operation room is preparing now.
Yes. I was speaking about a survey conducted by the ESTS meeting in 2016 about the use of sealants. There were 240 participants in this satellite symposium on the use of sealants, and were asked anonymously to respond through a power vote system to 6 multiple choice questions aimed at establishing the current standard of practice. The survey clarified that only a minority of surgeons use sealants routinely in their practice, 8%. On the other hand, 54% use these products only when indicated, while 21% prefer to have sealants available in the hospital for an exceptional use. Can you see the screen? Yes, no?
Yes, we can see you.
With regard to the technique of hemostasia,
excuse me, Dr. Ricardo, no puedo escucharte. Sí. Todavía, ahora sí.
Now,
Sí,
yes, with regard to the technique of hemostasis of fragile vascular structures, it was obvious that most surgeons would resort to unnecessary measures to ensure control of the bleeding, include sealants. However, the traditional methods of hemostasis represent a priority. Although 49% of the surgeons seem convinced that sealants do work and recognize that no definitive evidence is available, 34% were uncertain as to their possible clinical usefulness. Not surprisingly, 17% of the surgeons declared their skepticism and their willingness to be guided in the selection of these products by experts from industry. Sealants are used to prevent air leaks in 49% of the patients on fistulae, but also on bronchial stump after either lobectomies or pneumonectomies. In addition, 13% of the attendees reported to use sealants in an attempt at closing bronchopleural fistulas, while 7% of the surgeons use sealants also on other structures, that is, pleura. Almost 1/3 of the total showed some degree of versatility by declaring to use sealants for all the above indications. For all indications, fibrin glue, 30%, and surgical patch combining human fibrinogen and thrombin, 46%, were the most used sealants by our survey population. However, 17% of the surgeons could only identify the products by their brand names and not by their main chemical components. While half of the audience seems to prefer a specific sealants for specific indications, the remaining surgeons either express the willingness of deciding based on their own experience, 41%, or were not sure and confused by the variety of commercially available sealants, 9%. Finally, concerning air leaks, air sealants, are they cost-effective? The practice of medicine has a high economical implications that, for instance, in the community I work, supposes more than 40% of all incomes the government has. Care expenses expressed in this slide, the percentage of the gross national income has been increased in the last 15 years more than 8.1%. Is there enough money to pay that? Is it necessary to stop or at least decrease all these expenses? Is there an end in the welfare state in Europe? 3/4 of all the sanitary costs come from hospitals. As the time goes on, it is more and more clear that is a subliminary war between money and medicine, as this front page of the Time publication says. There are many causes of this expense that we cannot speak now, such as the of sealant is not alien problem. As you can imagine, all is studied in mechanical markets. This report details the complete range of sealant and glue technology. The report examines the clinical and technology development underlying this huge and rapidly growing market and forecasts competition market shares, competition profiles, and market opportunity. The report provides a worldwide forecast up to 2025 of the markets for these technologies, with particular emphasis on the market impact of technology through the coming decade. There are 104 companies profiles in the struggle in this field. The economical benefit is more than 2.4 billion for hemostasis and 1.7 billion. Also establishing a wide market size for major segment as a baseline for and projecting growth in the market over a 5-year for the report and projects of the use of technologies in medical specialties, thoracic surgery. So, are responsible percentage of the nation. We are concerned by effects, and we have to demonstrate effect of our practice. Gain efficiency, improving outcomes at lowest possible. As we have seen along this speed, air leaks are paramount importance. After all, we can do several kinds of conclusions. The general conclusions are: persistent air leak is frequently expensive. Persistent can be predicted and selected for prophylaxis. The use of air sealants is a safe test and with side effects. A level of evidence high. Reduction in incidence of air leak after use of sealants is observed in 70% of randomized studies with a level moderate. This reduction of air leaks in quantity and time doesn't influence other parameters like time or chest drains or hospital stay. Level of high. Due to studies and revisions like the one we present in this webinar, the study size used is a statistical rate recommended after lung resection with a level of recommendation of 2. Thank you very much for your attention and greetings from this hospital in Valencia, Spain, one of the oldest in Europe, which is over 500 years old. Thank you very much.
Thank you, Dr. Ricardo, for holding this excellent speech. It was a pleasure to listen and also to learn from you. And now let's welcome Professor Gabriela, who will give us more insights about the cost reduction of robotic surgery using EziSurg mechanical stapling.
Hi, thank you. First, I want to thank EziSurg for the invitation to this thoracic surgery exchange program. My topic is about our experience in the implementation of robotic thoracic surgery and how we try to make it viable in our center. We started the robotic thoracic surgery program back in 2017, being the first public hospital in Spain to perform this type of surgery. We did it after consolidate our learning curve in VATS type approach first. And of course, when our hospital received in possession the Vinci system robot. But early 2000, the use of robotic approach for thoracic surgery has been used in other countries like Italy, where Dr. Melfi take the challenge of robotic surgery, and she did it by skipping the learning curve VATS procedure. Since then, multiple comparative studies have demonstrated the benefit of minimal invasive approach, as you know, either by RATS, robotic, or VATS, compared with open thoracotomy. These include, which is performed through a small incision. It generates less pain and therefore less use of analgesic. There is less bleeding and consequently no need for postoperative transfusion, fewer respiratory complications, shortened hospital length stays, quicker functional return, a significant decrease of 30 days mortality, and greater lymph node assessment. However, controversy exists regarding the resource implication of the robotic approach, particularly when compared to VATS. Numerous publications, such as the first one was Dr. Park and Dr. Flores, Dr. Swanson and Dr. Dean described the higher direct cost of lobectomy by VATS, showing an increase approximately $3,000 or $4,000 over the VATS procedure. Also, other authors like Dr. Nazir with Dr. Serfolio describe that RATS approach can even generate profit. More recently, Dr. Nelser concluded that they are not different between the expenses generated between the three types of approaches. Also, it clarified that there is a better outcome after the use of minimal invasive technique. Obviously, part of the difference in the result of this study are due to different health policies, form of financiation, agreement between company and user, but the measurable costs are due or depend on expenditure associated with the system and disposable, the length of stay, the possible blood loss, and the less complication. As a surgeon, we also delegate the responsibility of making the use of the new technology feasible and making better use of the resource, especially when we understand that there is a real benefit for the patient. In this sense, we have found allies in efficient and affordable products, medical products such as easy endo staples, which also have an advantage over other staples with his extra full 60-degree articulation that allows us place from the assistant rocker without removing the arm used by the surgeon. There are another disposable like surgical aspirator or clip up that we use externally to robot system. Now you will see a 10 minutes edited video of a robotic right upper lobectomy and the use of this disposable instrument, which allows us to do the procedure to be carried out with reducing its cost. First, the patient is positioned the lateral decúbito with his arm in from his face, and we use a 4-arm techniques with an assistant port. 2 posterior arm and the assistant window in the 8th intercostal space, and 2 most anterior in the 6th intercostal space when we perform superior lobectomy. In this patient, mediastinal lymphadenectomy has already been performed, and we use the fissureless technique if we can. Now the right upper vein is isolated and separate of the right and separate from the confluence of the middle lobe vein. For his transection with a vascular type endostaple. It seems like a small detail, the use of this external staple, but each robotic staple has an approximated cost of 11,000 euros, which can only be used in 10 different patients. Then the isolation and stapling of the mediastinal branch of the pulmonary artery. And again, we use a vascular reload. Each reload robotic vascular staples is priced in 225 euros approximately. In this particular case, we use 7 reloads, and the average for lobectomy is between 4 and 6. Dissection of the iliac lymph node bronchial is made before this step. And then the preparation for stapling the right upper bronchus with a brim reload. We check the permeability of the intermediarius bronchus before use the stapler. And before completing the fissure, we dissected the dorsal ascending artery. I have to say that in the operation room next to the patient, there is another thoracic surgeon who is the one who introduced the endostaples, gauze, and provide aspiration. And in case of needle conversion, he is the first one beside the patient. There are also an aspiration system in the robotic arm, but we didn't use it. Because we use the external. And this kind of gauze, tubular gauze. Again, a vascular reload. We finally complete the anterior fissure with the middle lobe and the posterior fissure with the lower lobe, usually performed with stop. Through the assistant window, sometimes we place a to locate small lesion marked with radiopharmaceutical such a nanocall. At the end, the specimen is introduced into an endobag, as you know, and extracted through the utility incision. It usually is 12 millimeters long. A chest tube is usually inserted by the utility incision also. And that's it. We believe that there are non-measurable but important aspects of robotic-assisted thoracic surgery, as they are that allow to carry out more complex cases, such as bronchoplastic, chest wall resection, and a very large central tumor, or tumor with significantly iliac adenopathy. There also, we prefer this technique in morbidly obese patients because the robotic has large trockers to do it. They also improve the learning experience, especially when the option of having a second console for trainers. Far less attention has been given to functional outcome and long-term quality of life. This is the team I belong to. Now we are living in times of pandemic, and after it, we must resolve the effect of this pandemic in our patient. It seems to be related to the delay of the diagnosis and screening process during the pandemic. I want to encourage the realization of this type of events that allow us to stay connected. So thank you again for this experience and exchange.
Thank you very much for your excellent presentation. We learn much from your case. I think you do very well, I think I learned a lot from this video. Thank you very much. And any questions from Dr. Chen? Any questions?
Doctor, very good presentation, and I appreciate your techniques when you're doing the lobectomy by the robotic platform. My question is, how long have you been practicing this procedure using the Da Vinci technique? And from your experience, what is the biggest difference between the Da Vinci system with the traditional VET system? Because you know the platform is quite expensive, and there's a lot of saying about the advantage of this new robots. But from our experience, we don't really see the benefits that much, like compared to the traditional VET. So I just want to hear from your experience and your perspective about this new technique. Thanks.
Thanks for the question. We started the program 2017, and we are 3 surgeons in our team. So, but we share the robotic system with other specialties like urologists, for example, because we are an hospital of multiple specialties. Yes, the robotic surgery must improve the tactile capacity. It's the first difference between bats and rats. The surgeon has no tactile or haptic capacity. So sometimes in bats, we feel more than we see the structure, the anatomic structure. In robotic, you have to see because it's all you have. So I think the tactile capacity must be improved, and with the entry of new robotic system, it will be reduce the cost of the current system, because right now there is a monopoly of intuitive system. But I think in the future, the robotic system will be affordable for all.
Okay, thank you. Thanks.
Okay. Next section we will maybe move to the operating room. We have 3 cases, live surgery cases, so we can communicate with each other in the operating room. Okay. Thank you for your presentation. We learn a lot from your presentation. Thank you. And maybe next time, if we when maybe next we invite you in person. We hope to meet you in Shanghai Chest. Okay. Thank you.
Thanks a lot, because lack of the time, and we move to the next part. Okay, and arouse my partner to introduce the next part.
So first of all, thank you all professors from China, from Spain, for taking their time to prepare this presentation and giving us these excellent speeches. So now we will continue with the third part of this webinar, which is live surgery. First, Professor Hua will give case introductions, and then later during the surgery, he will also talk more detailed about the procedures.
Thank you. It's my pleasure to briefly introduce the 3 cases of today's operations. Today, our operations will be conducted by Professor Wentao Li, Professor Feng Yao, who just gave us the presentations, and also Professor Yunhai Yang, who is already in the operating room now. So the first case is adenocarcinoma. The first case is apical posterior segmentectomy of left upper lobe. Will be presented by Professor Feng Yao. This is a female patient who is 54 years old. And she had a GGO nodule in the left upper lobe found during the routine examination 2 years ago, and the nodule recently enlarged during the follow-up. So Professor Yao will give will do a 3D uniportal VAS of apical posterior segmentectomy of the upper lobe. So this is the first case. So this is the appearance of the nodule on CT, which you can see is about like 1 centimeter in diameter of GG and lesion in the left upper lobe. The second case is also a left upper lobectomy for mixed GGO for subsolid ground glass opacity, which is 34 millimeters in diameter, also located in the left upper lobe. This nodule is found also by a CT screening program. The patient had no symptoms. So we'll also give left upper lobectomy for this patient. This is the CT appearance of the nodule, which is quite large, and most of the region are solid part with only the peripheral area with some subsolid changes. And this is the third case is the opacity is a nodule located in the right upper lobe, and then Professor Wentao Li will give a Miniportal right upper lobectomy for this patient. So these are 3 cases of today. So I think we can now move to the operation room.
Oh, 1、2。 可以有。先帮我把眼睛开开，我先把洞打了，翻上去，对，再上去。还有一台没拉对吧？今天3号里不是很少的吗？为什么？哦。哎，也可以，我们不大受欢迎，就这样吧。是这个还是这个？你看一下，这个是定位的那个。完全浪费哦。好的，镜头好了吗？关灯，放眼镜，你们来弄一下。清晰。定位针是在结节的上方还是下方？正好在这个。有粘连感觉是。收到。完全。这里有粘连吗？看清楚。哎呀，你这个辅镜子真的是糟糕了，晃什么？ 打气。好的。
我也能听懂，来继续走。好的，这回你可以说两句。
It's the nice Liverpool note.
In room 11, there's a left upper lobectomy by Dr. Yang. And usually we dissect the lower mediastinum first to dissect the station 7 and 8 from the posterior side. In this case, we can better expose the posterior part of the hilum and expose the exit port of the fissure. So we're removing station 11. So both of the cases are conducted via the Uniportal approach. So we usually use the interspace of rib 5, the 5th rib space for the incision, which is usually 4 centimeters long. So in room 4, Dr. Yao is trying to dissect the fissure.
Yes.
It's a poorly developed fissure, so it takes time to find the space and then meticulously dissect the fissure.
Yes, we think for the apical posterior segmentectomy, we have to dissect the fissure. But actually, this is not a very big problem. We just need patience.
开了给我说一声啊！
干什么？
开了没有？开了没有？你给我说一声来，我用一下这个，用一下你先吧。来，我们现在开始。刀给我，好，等一下，赶快切，快速切，切好，切好要拍这个。换小的，换小的，换小的，换短的。
So in room 11, we see the dissection of the subcarinal region, subcarinal lymph node has almost completed. We need to expose both the left bronchus and the right bronchus when we do the lymph node dissection of this region.
对，拿干净的纱布上来，对，找它对个白，把镜子给我放好，焦距对，往这面上面一点呀，哎，你往后一点呀，太近了，面朝着我。 来倒给我，交接对一下。
In Shanghai Chest Hospital, we use the argon knife, which quite good for the hemostatic small bleeding control.
Actually, last time I went to Switzerland, you know, Dr. Chen.
Yeah.
Yeah, in 2019, you know, I went to Switzerland. So actually, they also have argon in the operating room for lung surgery.
Okay, it's very useful, especially for some peripheral bleeding, isn't it?
Yes.
And I think it's also good for air leak control. If you have small air leak, can you also use?
转播了没有？这是转播了。
Dr. Li, we can hear you very clearly.
Yeah. Okay. Thank you. And just
now move to the operation room. Okay. So
I want to show you the Miniport. A very small incision. It's a middle lobectomy. Good protector. Okay.
This patient is very easy to bleed.
进去。
哎呀，望着心。
OK。另外一个，哎，插镜头。
先够。
先到，插镜子，进去吸烟，插到里面吸，出来。
Professor Jorge and Professor Rodriguez, if you have any questions about the surgery or anything you noticed, you can ask. I'll try to give you explanations if you want.
来，进去吸。Oh, good, very clearly. Okay. 这是中液呀，放到中液里这里，这个病灶很小的一个，病灶非常小。这是这个可以看在这里，对，这是一个，所以我们看你来拿一下这里。
It's the fourth lymph node.
Very question from Spain to Professor.
When's first? Yeah.
Very question from Spain to Professor Wentao Li.
Yes.
Yeah.
When performing a semectomy, when do you prefer to do the lymphadenectomy? Before or after the lung resection?
After lobectomy, usually. If lower lobectomy, we usually did the lymph, number 7, and number 8, and number 9 lymph node.
A second question is, do you do the lymphadenectomy lobe guided or systematic?
Systematic.
Thank you very much.
来，这个把那个白丁给我，快点来。
这个不能翻译，杨主任，这个。
杨主任要低调一点，低调一点，来操刀。再拿这个，
把那个声音都能过来的。
把这个往这边，往这边走。
对。
Okay, so
再来这边拿一下，再拆个蓝点。The middle pulmonary ring first, and I use the T-string to hold the stem of the pulmonary ring, and up it, lift it, expose the pulmonary, expose the middle bronchus. 对，对焦，舌头前 ，just to make, okay. Yeah, and section like this, expose the right. Here is a lymph node, very small, and okay, look. 来，舌头前，等一下，来个蓝丁。
So Dr. Yao has almost finished the fissure.
Yes,
we just need the patience.
Very
always,
nice.
always.
Okay.
Go to the lymph node and check out. This lymph node is benign.
Yeah, they are the 6th lymph nodes. Section.
Number 11 lymph node. Let's take.
Hello. 开白丁。
这个，对，对，出来了吧？
对呀，这是白丁呗。来，放你钱。
来。
哦。
拿一钱。
这个是不可弯的，是吧？
轻一点啊。
这个不是转的吧？啊？
来，放你钱，轻一点啊。
啊，跟着下面走，跟着下面走 ，OK， 来，白丁。来，舌头前给我。
来进来。
这还是个两
转的，转的为什么调不了呢？没装好啊。
白丁 ，white stable. Here is a pulmonary artery. The two branches. The one is bigger, another small one. Usually we dissection the big. Doesn't matter. Just from here, let's look. Okay.
Dr. Yao?
Yes.
Do you use other type of system apart from staples to close the segmental vessel?
I'm sorry, I cannot hear very clearly.
do you use other types of system apart from staples, clips, or hemlock for segmental vessels?
Hemlock.
Hemlock, yeah, I like hemlock, especially small hemlock, you know.
Okay.
I like hemlock. I think this lymph node is calcified, you know, a little bit.
Okay. Then the arteries.
Dr. Yang has almost finished the arteries.
拿卢米。
来啊，进去。
你对镜子怎么扶的？
中文，直角拳，其实直角拳进去也不一定能够，但是会稍微好一点。
动脉是怎么说的？动脉，不是，就是断动脉。
等一下。
应该是贴动脉，或者是拧丢了。
OK， 来，好，白定。陈华。
哎，李主任。
这个就基本上快完了。
Okay, Dr. Li has almost finished the middle lobectomy.
对，
视野吗？
He's
不要自说自话行吗？
dissecting the artery, 2 arteries together.
练功。上面不知道要擦一下吗？
蓝丁，
姑娘。
蓝丁。
啊？
蓝丁来，然后再找这个间隙，间隙呢就在这里。
Lastly,
蓝丁。
only patients remain. 李主任，你这个很漂亮，这个很快。
不，中叶它有时候就按照这个方法做，它比较快，它不要去打开叶裂。打开叶裂做这个中叶反而变得比较。
操刀。
做的过程就是打叶裂。哎，其实叶裂都是最后靠这个打出来的。你看这水平裂就打出来了。The horizon fixture you just use the staple. Right to left 再给个 blue staple. No, we just close the.
Almost finished.
Okay, good. 来，舌头前给我把淋巴结丢住。来，淋巴结。舌头前给我。我把这组看一看。
看看。
So Dr. Yang is trying to dissect the lingular artery, which is the last artery of the upper lobe.
To Dr. Wentao,
yeah.
Did you change the localization of the incision for the port, or always try to stay above the ileum?
Try to say what? I'm sorry.
Do you prefer the localization of the incision always above the ileum?
The incision always above 是不是在每次都在这个 这个肺门上方这个做这个切口。
It's not. No, it's depending on the different resection. For some lobectomy, the incision maybe you can fix on some intercostal number 4, number 4, and number 5. But for some segmentectomy, it's a little bit different. It's dependent.
Okay, thank
you. It's dependent. At the beginning of my experience, the VAS, 2007 or 2008. I usually use a number first in the course to be the operating incision.
Okay.
But now it's still different. It depends on the different different. Okay, 来点到就，给我拿个5尺的暖气钳。
来，风力钳。
5尺暖气钳，我来把这个
决定
直的5尺暖气钳。
就转的最好。
提起来，好，来舌头钳给我。来，舌头钳，咱们往后看。Number 7. We can see the esophagus and this is subcranial lymph node, number 7. Oh, 推一下，不要太近，太近就粘上。
建构。
来拿个长的吸引器，换个长吸引器。剪掉。来，吸引器没了，吸引器没了，吸引器没了，插上。来，拿一下这个钳子。我把这个拿这个远一点，对，拉起来就行了。来，你看它吃的暖人钳不好。
让我来看。
第10组。净土。往这线稍微给一点好吗？
往上远一点。OK， 来，拿着。再来，看到第3往第7组左右，往上面，哎，对，这个东西小学上来，刚培养好一批走了。来，吸引器给我。 翻译一下。是吧？你来个白钉。我是靠分身把它分出来。然后这是。
To Dr. Joan, I have no experience with argon. The argon aspirator seems safer than bipolar when used in the pulmonary vessel, or is a risk also to burn the vessel?
对，是这样。
杨主任，他问你这个用这个氩气刀能不能处理肺动脉上面的出血
？Of course, why not?
Yeah, of course. It's no problem.
I think for small bleedings of the artery, you can try to, but I think for like some major bleeding, you can't use the argon knife. It's only for very small, very small bleed.
Okay.
看，这已经看到，这是 subcranial, no lymph node here.
Argon knife can be used for if you have some small blood leak when you finish the stapler. You know, sometimes you have the like small bleeding of the stapler line. So we only use that for when you treat the bleeding of the artery. But if you have like a small hole on the artery, usually it's better to control and then to maybe to suture. We don't use the argon knife to control that kind of bleed.
Okay, 来。
Okay. Thank you.
来，罗排看一眼，罗排看一眼。来，快点，快点，来。来，上过去。来，罗排看一眼。压紧一点，压紧一点，压紧一点，压紧我一点。有紧盯吗？ Yeah, I want to do the intercostal nervous blocks now.
One question to Dr. Wentao Li. How long does the air leak last when using the harmonic to dissect through lung parenchyma? How long, how many days in your experience lasts the air leak when using the harmonic?
李主任，他问你这个用超声刀分离液裂的话，大概这个肺裂如果要漏气的话，要漏多长时间？假设用超声刀分离液裂的话。
If use a harmonics, I think maybe 3 to 5 days after surgery.
Thank you, bro. Thank you.
往后退，顶着我了。 顶着我了，我对。
对，三指。
来，好了，来给我这个，给我那个什么，不是中安。开始。 哦，你看看其他的地方，我来把一个口子稍微看看其他地方，看看那个地方，我稍微往下走一点。成功，不要，好嘞。好，来把这个看一下这里，来现在。 Let's just make large the intercostal. 这是把短的信息来给我这个。 在它的绿钉。好了，可以来，现在手套。位置还是比较低的。Usually we use the plastic glove to take out the specimen. One can get. Something like this. Okay. 不要动，我要打枪的时候，你手不要上来。枪。好，来。
Yeah. His brother from China did such a nice job.
OK， 来盯着，不要动，你不要动手。
Yes, great.
OK， 来。啥意思？射，来。啊？你来，是这个吧？来看哪个小的，哪个小的这部分，我先把它先塞进去啊。嗯。OK。啊，可以。OK。打的够不够？啊。哎呀，吃到这喷一次。哎，是那个什么舌头，那个什么直接杀。来看，没有在这口上面。
需要鼓一下肺吗？
直接杀住。舌头前不要下去了。有没有血了？好，你早点回家。我看看。来一个白钉吧。好，胸管。
It's the failure for the last step.
Okay. Take on. 来，胸管。胸管。拿普通胸管，快点。24号的胸管拆一个。24号胸管拆一个，放。再来一个蓝钉。等一下。
4号为什么
？A blue one.
不对。
A blue one for the last. 来，爬镜子。你可以出来了。Okay, after surgery, just a very small incision, 1 finger.
Dr. Li has just finished. You can see the incisions.
Yeah,看.
It's the Miniportal approach.
Okay, give me. 来，舌头前给我，把它放开，不要去限制我。
Dr. Jiang is also trying to remove the specimen using a glove.
来，舌头前给我，不要动，不要动。就在针的旁边的，挡我，来塞一下，塞。那就在里面，没问题。对，30度。先放在这里，先不要送啊。对，180度，正好了，手底下蛮快的嘛。OK, finish. Alright then. Okay, well, that's the main part. It's very, very small. Okay, finish. 你拿着，你来分吧。Okay, I just I finished this. This is two branch artery. 别了。
And this is the bronchus, apical posterior
不，这打呀，
bronchus.
等一会儿不要急啊，他现在还在转播的，
And this is
打着把那个
the
切口啃掉。
vein stump.
小猪打进老薛了是。
For this, because this is a PGO patient, so we don't have need to do systemic lymph node fixation enough for this patient. Because as you can see, this patient with the lymph nodes is not with maybe inflammation.
他们因为说的地道呀。
use argon. Silent foreign chair.
So Dr. Gabriela and Ricardo, do you have any questions? You can ask. I think 3 cases almost completed.
Actually, in case of small leak, I want to just just like Dr. Ricardo mentioned.
Here. Here's the small leakage. Yeah.
，OK， 好了。来，好。录像可以停止了。
Yes.
可以关闭了。
Due to a rupture in the pleural surface.
Yeah, you can use the argon knife.
You 放下来，不要动。这样，轻一点，轻一点，轻一点。这个地方帮我理。松线打结，松那个线多。
姚主任，这个画面好像有点卡住了。是他们那边的。是吧？
啊，卡住了。
这姚主任，你这个画面好像有点卡住了。
对。
但是大部分现在稍微有点卡，但是
转过来呢。
大部分的这个。
他们转播的人说，我这个卡住，我这边是卡住的。
嗯。
那你们去沟通呀，这个现场说我卡住的呀，你们还要问我啊？我哪知道卡不卡呀？咦，这个真的是。
11/9的结束了，对对对。OK， 姚主任，你那边什么情况？你看不见，他这个可能音频有点卡。要么调整。
我这边你们看不见对吧？
就是
肺已经下来了，
视频，肺已经下来了对吧？ 现在在放胸管了是吧？
没有，我在补肺。那就结束了。
OK。
就结束吧。
Okay, I think thanks to Dr. Yao, Dr. Yang, Dr. Li for 3 nice cases of lobectomy and segmentectomy. So Dr. Gabriela and Ricardo, I think all 3 Chinese surgeons have finished the cases. Do you have any questions or comments on these 3 cases? We'd like to hear from your opinions, and also we'd like to give any answers if you have any questions.
Well, for me, I have been surprised that instead of bags, you use gloves for putting the piece inside. So the economicity is a very good question in your hospital. Instead of using bags, you use gloves.
Gloves. Thank you.
Good idea.
So it's much cheaper.
Yes, much more cheaper.
Thanks for this amazing incredible fast surgeries. I have one issue.
Yes.
When you find calcified lymphadenectomy attached to the esophagus, you continue the resection, or the possibility of esophageal perforation change its behavior in the right side?
Sorry? Can you
when you find calcified lymph node
yes,
attached to the esophagus.
Yeah, to the surface, to the artery.
Yeah, no, to the esophagus in the right side.
To the esophagus, to the right side.
Yeah.
Okay.
Yeah, that change.
No, a little bit.
That changed the way you perform the surgery, or you stop the surgery because the possibility of esophageal perforation?
Okay.
If you have a I want to repeat your question to see whether I understand your question well. If you have a calcified lymph node attached to the esophagus, do you change the procedure? You stop the procedure, or you continue the procedure
exactly
to finish the lobectomy? So I think we if you see the lymph node, the adenopathy attached to the lymph esophagus, we would do a biopsy of the lymph nodes and do a frozen section to see whether this is a benign node or a malignant node. If it's a malignant node, we're gonna have to re-evaluate the degree of the malignancy to see whether we can completely resect the tumor. If not, probably we're gonna stop the procedure. But if you can remove the lymph nodes, we're probably gonna finish the lobectomy and ask the patient to continue with radiation after surgery, I think. I don't know whether I answered your question.
Yeah, you did it.
Okay.
Perfectly.
Thank you. Yeah.
Do you have any questions? Dr. Ricardo, Gabriela, any questions? More questions?
No. Okay.
No, and then our webinar will be end now. And muchísimas gracias.
I want to say something. I want to say for closing. First of all, excuse again the technical inconvenience. It has been a great honor for us to participate in this academic exchange, China-Spain, and we hope we all have learned a lot and take advantage of it. I want you all to invite to know Spain, and in my case, to know my hospital, one of the oldest hospitals in Europe, founded in 1912, and the first in our country in having recently, right now, a chair in robotic surgery for teaching in 4 specialties: general and digestive surgery, thoracic surgery, urology, and gynecology. We intend to develop a master in laparothoracoscopic and robotic surgery, which will begin next September. You are all invited to participate in it for the best of the progress in our specialty in both countries. Thank you very much, and has been a full pleasure to share this webinar with you all. Thank you.
Thank you too. Yeah, really appreciate. And after the pandemic, we would like to invite you, two of you, to visit here in Shanghai Chest Hospital.
Yes.
Yeah, it's really welcome.
Both of you are very welcome, and also your colleagues from Europe would like to have not a virtual meeting, but a real meeting in either Shanghai or in Spain. You're all welcomed.
I hope so. Thank you very much.
Thank you very much. Introduce a bridge between China and Spain.
再检查一下。
Yeah.
我来找杰杰。
好，差不多结束了。
结束了。
好 ，OK.
Okay.
So, Dr. Yao, do you have any more comments on the on this meeting or the surgery?
No, thank you. So we hope to meet each other in Shanghai or in Spain next time. Okay, maybe next year. Okay.
Thank you. Very nice.
Thank you for joining us this afternoon. Okay. Thank you. See you next time.
Wonderful demonstration. Thank you very much.
Thank you.
好，结束了。OK.
Muchísimas gracias. Yeah.
Okay. Bye bye.
Bye bye.
Bye bye. Un placer, doctor Guijarro.
Gracias, Gabriela, por todo.
A ti.